disruptive, and so on there. And so, it was quite an eye-opening experience for me, but it was also an experience that I found very, very challenging and rewarding. In particular, I remember, the patient that I worked with was a teenage boy, profound intellectual disability and autism, minimal verbal behavior. He engaged in very, very severe self-injurious behavior. It was primarily hand-to-head self-injurious behavior to the back of his head. And he hit himself so frequently and with such force that he had bald spots on the back of his head there. And again, as like a 20-year-old college student, I was just floored that, someone would hit themselves that hard and that frequently without feeling pain, essentially. But I was also, amazed that there is this technology called applied behavior analysis, or ABA, that could actually help that person with profound intellectual disabilities and profound autism there. To the point where when he was discharged from the hospital, he had very low levels of self-injurious behavior. He could start doing, basic, I guess, academic and vocational type tasks. And he was actually went back to his residential placement back in Maryland there. So it was at that point of, I really found my career path. Up until then, I was a lost college psychology major, had no clue what I wanted to do with the bachelor's degree in psychology. But fortunately, that just kind of jump-started my interest in the field of ABA. After I graduated from college, I was fortunate enough to work at that same hospital for 3 years. I loved it even more, just found it very challenging and rewarding. And I had the opportunity to go to graduate school at the University of Florida and get my PhD. But to this day, although I spend a lot more time training graduate students, I still am very involved in the clinical treatment of these problem behaviors, as well as research related to these very challenging behaviors as well. So really just to kind of give you an idea, much of my clinical work and research to this day continues to be focused on supporting people with autism and other neurodevelopmental disabilities, particularly those who engage in these very severe problem behaviors, or these complex problem behaviors. Right now, I know that all of you guys working in the state of psychiatric hospitals, as Dawn mentioned, I do also serve as a consultant, where I help provide clinical supervision and support to the behavior analysts, or the BCBAs, at the hospitals. And I'll talk more about the behavior analysts at the hospitals, just in case you're not familiar with that particular position or those particular individuals. And they really are a wonderful group of people there. But just to give you an idea of the behaviors, I suspect a lot of you, probably are already familiar with these problem behaviors. But just to give you an idea, this is an example of one of the patients that I worked over my career. This was a teenage girl with profound intellectual disability who engaged in really, really severe self-injurious behavior. If left alone, she would hit herself thousands of times a day. Even with the protective equipment like the helmet there, she would still engage in the high frequency and high intensity self-injurious behavior. Right, so that's just an example of this someone who engaged in very, very severe problem behavior, self-injurious behavior in this particular case. I mean, that's just to give you an idea of what I refer to as complex problem behaviors. And I'll come back to her at the end of my talk. Just to kind of frame these problem behaviors again. I'm really going to focus on, well, because the vast majority of my research and clinical work has focused on people with autism and developmental disabilities. Really, just about everything I'm talking about is based on my experience in the research with that particular population. I know that in the hospitals that you do also have patients with autism and intellectual disabilities and developmental disabilities, but I also know that you have patients who don't have those diagnoses and who have other psychiatric disorders there. What I'm hoping is that by using this this model, that we've used very successfully with people with autism and developmental disabilities, you can also see how it could apply to these complex problem behaviors that are exhibited by your other patients at the hospital as well. Now, to give you an idea of how common these problem behaviors are, at least within the autistic population, it turns out that they are very, very common, right? So if you look at this, studies looking at the prevalence of these problem behaviors, it ranges anywhere from 10% to as high as 70% of individuals with autism are estimated to engage in some level of problem behaviors. Now, in all likelihood, the 70% doesn't necessarily include, it doesn't completely include, like the really, really challenging, self-injurious aggressive behaviors. But nevertheless, a large percentage of people with autism do engage in these problem behaviors. Common types of problem behaviors will be self-injurious behaviors. Again, I suspect that these are behaviors that you'll see quite often in the hospitals. Well, I know that you guys see in the hospitals. Self-injurious behaviors such as head hitting, head banging, self-biting. We see a lot of aggressive behaviors, scratching, kicking, biting, biting others, punching, and then property destruction, such as breaking objects and throwing objects there. These aren't to say that these are the only types of complex problem behaviors that we see or that we'll treat. Obviously there are lots of other problem behaviors that are exhibited by this particular populations. Behaviors such as pica, rumination, coprophagia, and so lots of other behaviors that might be less common than SIB aggression and property destruction, but still very problematic nonetheless. Now, in terms of some of the adverse consequences associated with these, as you would expect, those people who engage in self-injurious behavior or aggressive behavior will cause injuries to themselves or to others. And so, people who engage in self-injurious behavior, oftentimes they involve the damages can be as minor as soft tissue lacerations and contusions, so bruises, to something more severe, such as eye damage. Previously, when I used to work at the Kennedy Krieger Institute, the hospital in Baltimore, we had a fair number of patients who engaged in really severe hand-to-head self-injurious behavior where they hit themselves in the temple. And so they would detach their retina because as a result of that frequent and intense hand-to-head self-injurious behavior. So that's probably one of the most extreme injuries as a result of these complex problem behaviors, at least that I've seen. But then in addition to these direct consequences, right, these injuries to themselves and to the others, there are lots of other indirect consequences that come about from these behaviors there. All right, so these behaviors interfere with therapeutic activities. If these are school-age children or individuals, it really makes it difficult for them to go to school and to learn while they're in school there. If these are older teenagers and adults, it makes these problem behaviors will interfere with vocational activities or going into the community there. We also see that these problem behaviors will interfere with, limiting opportunities for community placements there, because a lot of the community placements aren't really well equipped or well staffed to try to safely address these very challenging or complex problem behaviors. And then we also see, particularly for the younger individuals, that they are likely to be placed outside their parents' home. And then finally, what we also see is that people who engage in these very complex problem behaviors are oftentimes exposed to both physical and chemical restraints there, and that would limit their participation in, again, therapeutic activities. And there are a lot of side effects associated with the use of physical as well as chemical restraints. Right. I should have mentioned at the beginning, I'm at home presenting here, and I've got 2 dogs. So hopefully they'll be pretty quiet during this presentation. But if you hear them barking, they are defending me from the neighborhood dogs and neighbors here. So they're doing their job there. So I apologize in advance if they do say that there. Right. Now, the final consequence we see is that, once these, particularly children, obviously, once they age out of school, about 21 years old, they lose a considerable amount of support, particularly people with autism and developmental disabilities. So once they age out of school, it's as if they've come across this cliff where they lose all these supports that were available to them when they were 21 years or younger there. And so that results in difficulties with community placement, vocational placement, and so on there, unfortunately. Now, so what I'm going to talk about today is really just providing you a broad overview of applied behavior analysis. Some of you guys might be familiar with it. I hope many of you are, because in my work with the BCBAs at the hospitals, we've tried to communicate across all the disciplines what the behavior analysts or the BCBAs can do to help support your patients throughout your hospitals there. But for those of you guys who might not be familiar with applied behavior analysis, it is ABA is the application of behavioral science to improve socially important behavior and to improve the quality of life for individuals, families, and communities, right? So what it's really designed to do is to help understand why these individuals engage in specific behaviors, how the behaviors are affected by the environment, and how learning takes place there. Okay, so really the bottom line is that research shows and clinical work shows that these complex problem behaviors are oftentimes learned behaviors. So they're really a product of the environment. Now, just to kind of give you a quick little history of applied behavior analysis there. Really, the conceptual and the scientific foundations date back to the early 1900s. For those of you who might have been psychology majors in school, you most likely have heard of Thorndike, Watson, Pavlov, and Skinner there, right? So these are kind of like the early pioneers or the early researchers that have within of applied behavior analysis that have gotten to the point where we are now. And so in the early conceptual foundations date back to the early 1900s. Applied research, it started probably in 19 excuse me. Applied research started about the 1950s. And it's really important to recognize that, excuse me, really important to recognize that all this research really supports the evidence-based nature of ABA as an intervention. And it's all this evidence has resulted in multiple endorsements by government, professional, and scientific organizations there. Just to give you an idea, the U.S. Surgeon General, the top physician in the United States, back in, I think this was 1999, it's been a little while ago, provided a report on mental health. And in that report, they stated that 30 years of research demonstrated the efficacy of applied behavioral methods in reducing inappropriate behavior and increasing communication, learning, and appropriate behavior there, right? So this is always, this is way back in 1999, where ABA wasn't as common as it is now. But the U.S. Surgeon General saying that ABA is an evidence-based treatment. Now, here's an example of a professional organization that is, I guess, advocating for the use of ABA-based intervention here. This is a report from the American Academy of Pediatrics, which is the leading professional organization for pediatricians. And they came out with a position paper on really the management of autism. And a couple of things they to highlight is that they concluded that most evidence-based treatment models are based on the principles of ABA, or applied behavior analysis, and the use of ABA methods to treat symptoms of autism suggests that behaviors exhibited can be altered by programmatically reinforcing skills related to communication and other skill acquisitions there. All right, and this was a fairly recent paper within the last few years there, right? And so, like, these are really but two examples of professional organizations and government organizations that are endorsing the use of ABA, particularly with the autistic population. There are lots of other organizations, such as the American Academy of Child and Adolescent Psychiatry, American Association on Intellectual Disabilities, as well as the National Institutes of Health, who have also endorsed the use of ABA based on the science that demonstrates the efficacy of ABA methods to treat these behaviors. Now, why is ABA such a powerful tool for treating these behaviors here? Well, really, I think it falls back to the characteristics of ABA. And so, it really starts with objective and reliable measurement of behavior, right? And the focus is always on objective and observable behavior. right? So when we're talking about behaviors such as self-injurious behavior, aggression, we will develop very concise and exhaustive operational definitions of those behaviors, so that anyone who is supporting that individual or that patient will know that that is the behavior that is the focus and the target there. We also rely upon direct observation of the behavior. So you may see, like the behavior analysts or the BSTs, walking around your units, kind of just observing, collecting data. They'll, rely upon the nursing reports as a means of data as well. And so it's that direct observation of the data that also, provides a useful tool for us in determining whether or not our treatments are effective or not. The ABA also really focuses on the environmental determinants of behavior, right? So it's, how does the environment affect these very complex problem behaviors? I recognize that, all the patients that you guys have come in with very complicated diagnoses and very complicated histories there. Their history and their diagnosis, clearly play a part in these behaviors. But it's really what research shows and clinical work supports is that it's how we respond to these behaviors that really affects these behaviors. So I mentioned at the beginning of my presentation that these behaviors are learned behaviors. So just as we would learn any new behavior, any new skills, the patients that you guys are working with are learning these aggressive behaviors and these self-injurious behaviors as well through the principles of reinforcement there. And the final characteristic of ABA, that really allows it to be such a powerful tool is a very rigorous treatment evaluation. So, we objectively and reliably measure the behavior. We look to the environment to see what's causing the behavior. But then once we have that information, we're able to develop behavioral interventions in which we're able to rigorously evaluate whether or not our treatments are truly responsible for any improvements in the behavior, or if it's some extraneous variable there. Now, going back to the idea that these are all learned behaviors. When we look at behaviors such as self-injurious behaviors or aggression, we're really focused on looking at trying to identify the functions of these problem behaviors. And so, in other words, what are the environmental causes of these behaviors? Or another way to look at it is what are the patients, what are these individuals getting out of getting by engaging these behaviors? And so we look at these behaviors in what we refer to as this three-term contingency, this antecedent, behavior, and consequence relationship. And so if looking at aggression as an example, oftentimes there is some antecedent that will trigger these behaviors. And oftentimes there is some consequence that is being provided following the behaviors there, right? And so that's where we get this ABC relationship. The antecedents that precede the behavior will trigger the behaviors, and then the consequence that will follow the behaviors or reinforce the behaviors there. And it is this three-term contingency, this ABC contingency, that really accounts for how that your patients and other individuals who engage in these complex behaviors will learn these problem behaviors there. Let me give you an example of some common examples of behavioral functions there. And I suspect that you will most likely see this quite often with the patients that you work with in terms of what the antecedents and consequences might be. So one of the most common reasons for these problem behaviors is the attention that the people might get, or access to tangible items there, right? So we'll refer to this as positive reinforcement. They're getting something that leads to reinforcing the behavior that leads to the future occurrence of that behavior there. So if we focus specifically on attention, let's say, attention is probably one of the most common things that are provided when someone engages in aggressive behaviors, for example, which makes complete sense, right? So if I'm a parent and my child becomes aggressive, the first thing that I'm going to do or say is, why are you doing this? You're going to hurt me. You have to stop doing this now. But what we find is that for some people, that attention is a reinforcer for the problem behaviors, so that the next time the person wants, let's say, the parent's attention, they are more likely to engage in the aggressive behaviors because they've learned in the past that when I'm aggressive, that people will start giving me attention there, right? And it could be the case that, the parents are really, really busy, and so they don't really have the opportunity. The parents don't have a lot of time to provide a lot of attention to the kids because, the parents are busy. They've got lots of things to do. They've got other kids in the house, and so on. And so the most likely way that the child can gain the parent's attention is through being aggressive there, right? So that's what so that is what we refer to as an attention function. Now, another way, another function of behavior that we see is access to preferred items or tangible items, right? So again, you might have a child who's minimally verbal, and so, but perhaps they want a toy, or they want a preferred foods or a snack, but they're denied access to these preferred foods or snacks there, right? But what they've learned is that when they become aggressive, the parents or caregivers in general might give them their preferred toys or their preferred snacks to try to calm them down and to like really de-escalate the situation there. But what unfortunately what's happening is that the child is inadvertently learning that when I become aggressive, I will get something that I want. So I will get preferred snacks, or I will get like really highly desirable toys or activities there when I become aggressive. So the next time I want these preferred snacks or these activities or toys, I will become aggressive to get these things there. Right? Another situation or function would be escape from demands, and this is what we refer to as a negative reinforcement contingency. So the kids have learned that when they engage in aggressive behaviors, things that they will no longer have to do things that they don't want to do. And a really common example would be in the school or the classroom. So, when they are presented with a demand, some type of schoolwork, they're really tired, they don't want to do it, it's really difficult, whatever the reason is, and the child, let's say, pushes the materials away, but the teachers are really, really persistent. They're awesome teachers. They want the student to learn, but they persist. But the student continues to push, and then finally that push becomes this a hit, accidentally hitting the teacher. The teacher is really surprised because in shock. And they say, okay, looks like you need to calm down for a little bit. So let's take a little bit of a breather, and then we'll come back to this there. Again, as the teacher is wonderful in trying to do the best for the child. But again, the child is inadvertently learning that when I am aggressive, the teacher will walk away and leave me alone there. And so that is an example of an escape contingency. The final contingency is or function is what we refer to as automatic reinforcement or sensory stimulation. So there's some kids who engage in like really severe self-injurious behavior, where they're getting some type of internal stimulation. We don't really know what it is, but they're getting some type of internal stimulation. Doesn't matter how people respond to them out in the environment, but and those action behaviors I find to be the most challenging behaviors, or the function to actually work with or treat, because it's something that's really difficult to try to stop. Okay. All right. So those are just examples of some of the more common functions of behavior. But again, it's not to say that they're the only functions of behavior. So there might be more idiosyncratic functions as well. And so, for example, people with autism in particular, there are some kids with autism where if you interrupt their ritualistic behavior, that might occasion aggressive behaviors there. And we work with a couple kids like that as well. So again, like these examples are fairly common examples, but that's not to say that they're the only examples. So I mentioned the importance of the functions of behavior, right? So it's really important to understand what the cause of the behaviors are. And we have a set of behavioral assessments that we use to try to determine what the cause of these behaviors are, right? So these, and they're called functional assessments, or if you've ever worked in the school, you might hear the term functional behavioral assessment, or FBA. And FBAs, or functional assessments, are a set of 3 different behavioral assessments that are designed to try to identify what the antecedents are and what the consequences are to these problem behaviors. Remember that 3-term ABC contingency? Well, these FBAs, or the functional assessments, are designed to try to identify what are the antecedents that trigger the behaviors and what are the consequences that reinforce or follow the behaviors there. And the three different types of assessments are what's called an indirect assessment. These are questionnaires. They're really quick to do. They're essentially screening tools. They might provide some information, but they have some questionable validity. There's also what we refer to as descriptive analysis or descriptive assessment. You might see BSTs or the behavior analysts walking around and recording, like what the antecedents are that immediately happen before the behavior, and the consequences are that immediately follow the behaviors there. And so that what that allows us to do is to really find a correlation between these antecedents, the behavior, and then the consequences and the behavior there. The final type of assessment is really the most powerful assessment, is the functional analysis. And that's when we're actually exposing them to the antecedents and the consequences to test out whether or not the function is attention, escape, or access to tangibles, or some other variable there. Just to give you a quick little overview of the functional analysis there, that it's that third one that's the most powerful tool that we have. What we're essentially doing is we're exposing them to test conditions in which they are likely to receive demands. They're likely to receive attention contingent on problem behaviors, access to tangible items as well, contingent on these problem behaviors. And these are really just analogs or simulations of what's already likely happening in the person's naturalistic environment there. And what we do is we do brief sessions, but we repeat them over and over. So we start to see that responding, let's say aggression is higher in the attention condition relative to some of the other conditions. And that would indicate to us that the aggressions are maintained by attention or positive reinforcement there. Okay. So I mentioned that those functional behavior assessments, those FBAs, they're designed to identify what the antecedents are and the consequences are, and really to have a better understanding of how the environment affects these complex problem behaviors there. And the benefits of these is that once we know what the antecedents are, right? So like what are the triggers for these problem behaviors? We're then able to develop treatments that modify those antecedents to really prevent these behaviors from occurring. So if we know that the presentation of demands, like some type of schoolwork, academic work, or vocational work, will trigger these problem behaviors, then we can modify, let's say, the presentation of demands. Perhaps we start with only one demand and we gradually increase, or we start with easy demands and introduce more difficult demands, right? But that will allow us to modify those triggers or those antecedents to try to prevent the behaviors from occurring in the first place. What it also, like the functional assessments also allow us to, once we identify what the consequences are or the reinforcers are for the problem behaviors, that allows us to modify those. So hopefully the patients aren't getting, that consequence or that reinforcer for those problem behaviors. So for example, if a person engages in aggressive behavior because they're seeking out that attention, then what we would most likely want to do is to try to stop providing that attention contingent on the aggressive behaviors, because that's only going to exacerbate the problem there, right? By the time that they reach you guys in the hospital, all likelihood, lots of people have told the patients not to be aggressive, not to be self-injurious. But obviously that hasn't worked if they've gone, if they've made it all the way to the hospital with you there. The third thing is, I'm sorry, I kind of mixed it up, is eliminating reinforcement. Well, also, like if we're able to identify the reinforcers that maintain the behaviors, we're also able to teach the people like more appropriate ways to seek out those consequences or those reinforcers. So if they are, again, seeking out attention, rather than being aggressive to get attention, we can teach the person more appropriate behaviors. For example, they can say, "Excuse me." If they're nonverbal, they can raise their hand or they can hand over a picture card, right? Something that's more appropriate, that replaces the aggressive behavior, and that will result in what it is that person or that patient wants there. And then the final thing is eliminating reinforcement, which is where we stop providing that attention or that the consequence continue on the problem behavior there, right? Just to give you an idea, so it's, again, the importance of knowing what the function of the behavior is or the cause of the behavior. This is a review paper that we did a while ago. It's a little dated now, but I still love these data. These data show the difference between treatments that are based on the functions of the behavior, right? So, if we, the no columns would represent, the research studies didn't know what the function of the behavior or the cause of the behavior was. So they just essentially guessed about what the behavioral treatment should be. Whereas the yes column shows you like treatments that were based on the function. And so the treatment was specifically targeting the cause of the behavior. And this table shows you the percentage reduction. And essentially what it shows you is the red boxes show you that when treatments are based on the function, so like we're specifically targeting the cause of the behavior, treatments tend to be more effective than if the treatment was not based on function, so simply guessing as to what a treatment might be there. Okay. So just to kind of summarize the behavioral assessment treatment model, right? So I mentioned that we define the behaviors, so that they're observable and measurable, and then we develop a measurement system. We conduct those, that functional behavioral assessment that I mentioned, that functional assessment, and that's to identify what the cause of the behavior is. But then once we know what the cause of the behavior is, then that allows us to really, that's essentially a roadmap as to how we go about treating the behavior, right? So again, if we know that, for example, the behavior is maintained by attention, then we can develop a treatment specifically targeting that cause. And that treatment could be teaching the individual more appropriate ways to seek out attention, and then also teaching caregivers to stop attending to those aggressive behaviors as well. I'm going to provide you with a case example just to kind of give you like an idea of like what it looks like from start to finish here. Okay. All right, I'm just going to pause it here. So just to give you a little background, so this is a patient back at the hospital that I used to work at in Baltimore. At that time, he's 11 years old. He back then, his diagnosis was pervasive developmental disorder. So nowadays it would just be autism. Also had bipolar disorder, ADHD, distracted behavior disorder. He was actually on lots of different medications, Abilify, lithium, Depakote, Kajectin, clonidine. So at some point in his life, he had those medications. Because he engaged in such severe aggressive behaviors, he lost his public school placement, and he had actually been in a residential school, but they discharged him because they couldn't deal with his problem behaviors. So when he came to the inpatient unit at Kennedy Krieger Institute, he had no school placement or no residential placement because his parents couldn't take him back either. They just weren't able to deal with his problem behaviors there. Here's an example of the severity of his behaviors here. This is an example of a situation where, when he's denied access to preferred activities or preferred objects, so this is cartoons, he immediately became aggressive because, again, he had learned in the past that I can get whatever I want when I'm aggressive there. And then this is a demand situation, schoolwork situation. So also whenever he was presented with any type of schoolwork, so this is a simple worksheet, he had learned that as long as he's aggressive, people will stop making him do schoolwork or stop making him do things he doesn't want to do. Right, so you can see that the staff was wearing a lot of protective equipment as well for their safety. All right. So just to kind of give you an idea, I mentioned that we operationalized the behavior. So, we wanted to be really descriptive about what the target behaviors are. And these are descriptions of behaviors. His primary behaviors of concern were aggression, but he was also verbally aggressive, cursing, threatening. engaged in a lot of property destruction, and then he also, spat at people as well.
Dr. Kang, there was a question that came in. Was that video taken during a functional analysis?
It was, yep. That was one of our functional analysis session, right? So again, that functional analysis session simulates what's already happening in the home, because what we know is that whenever he was at school, he would become aggressive whenever they tried to get into schoolwork, and whenever he was denied access to his favorite, I think those were comic books, he immediately became aggressive and got those comic books back. The second step is, once we operationally identified the behaviors and identified what the problem behaviors were, we developed an observation and measurement system, right? So we directly observed the behavior, and we recorded each occurrence of those target behaviors. So we were able to measure the frequency of behaviors, because again, that's how we're able to objectively determine whether or not the treatment is actually effective. And then we did our behavioral assessment. So we did that functional analysis where we test the different conditions, right? So we're actually testing for the antecedents or the triggers and the consequences. And then we also made some modifications based on his responding and parental caregiver reports there, right? So I think one of the things about ABA is that it is a very individualized approach, very personalized approach to support there. So like the treatments that we developed, the assessments that we conducted are very different for each individual based on their needs there. And so we did do that functional analysis with him. And then these are the graphs, and I just want to really highlight the last graph over there. Each of those different data paths, so like the open squares represents the situations where where he's denied access to preferred items. The triangles represent those situations in which we present demands to him or schoolwork to him. The closed squares represent the attention. So when he's engaged in these behaviors, we're delivering those reprimands of telling him to stop. And then actually the diamonds represent what we refer to as a divided attention condition, because the mother reported that whenever she's talking to somebody else, he immediately becomes aggressive to try to get her attention. So that's a simulation of that particular environment there. And there's also what you'll see is a play condition. That's a control condition where kind of in a perfect world for that patient, no demands, lots of awesome toys, lots of wonderful attention. What's going to happen? It should be low problem behaviors. And what we saw with him is, just to show you how complicated or complex his problem behaviors are, is that he did it for multiple reasons, right? So he's learned over time that he can get preferred items by engaging in items, activity or problem behaviors like the comic books. He can get lots of attention from his mother and from other people from engaging in his problem behaviors. And then he can also get out of doing any type of schoolwork by engaging in these problem behaviors there, right? So he can get he engaged in there were multiple functions and multiple reasons for his problem behaviors. And so in terms of once we knew what the functions of his problem behaviors, then we set out to develop a treatment specifically for him and to evaluate that treatment there. And the goal, the general hospital goal is always an 80% or greater reduction. But again, we would also have an individualized goal for him as well. And the treatment for him was relatively straightforward, though it did take a lot of time. So it's what we refer to as non-contingent attention. So attention was such a powerful reinforcer for him that we made sure that all caregivers would consistently just give him free attention throughout the day, right? So what we found in his life is that the only time that school staff, for example, were giving him any attention was when he became aggressive. And so we wanted to flip that so he would just get attention throughout the day. And so he didn't need to be aggressive to get attention. And we also did a my way, what we refer to as a my way, your way treatment, where we taught him that there are times where it's okay to do things your way, right? So no schoolwork, you're going to have access to really cool things. But then there are also times, just like in anyone's life, that you need to do things that are our way, essentially, right? So you need to do schoolwork. You need to put away your toys. You need to clean up your toys. And so it was a balance of teaching him, well, there are times that you can do things your way, and there are times of things that you need to do our way. But it was a very gradual process, right? So initially, he got to do things his way a lot. And we would only ask him to do things our way very, very little. But we gradually flipped that so that by the end, I think it was maybe every hour, he would do 15 minutes of his way, and then 45 minutes of our way. That was a very gradual process where we started, I think, much more of his way and then flipped it to our way there. Here are the treatments. Again, lots of data there. I'm going to ask you to focus on that very last phase over there, where you see that the treatment resulted in almost near completion of his or elimination of his problem behaviors there. Right. And we were able to train the parents, and this is actually a video with his parents as well as other caregivers. And this is a play situation where we're going to ask him to share the toy there at some point. Oh, yeah. And then this is a demand situation where we're having to do those same type of worksheets previously that he had previously been asked to do. And I always like to point out that these are pretty boring videos, but obviously in our line of work, boring is actually a good thing. All right. Oh, sorry. All right. So very boring, but a good thing. So just to kind of give summarize his particular treatment there, or inpatient admission there. I'm sorry. Let me back up there. Just to kind of summarize his inpatient admission. This was a relatively young child who had a long history of engaging in these problem behaviors there, right? So he'd been doing them ever since he was about 3 or 4 years old. He's lost, his parents could no longer keep him in his home because he was too dangerous for everybody in the home. He had lost his public school placement, his residential placement, and to the point where he had developed a reputation where nobody was willing to take him there. Fortunately, after the treatment there, they found a placement for him in the New England area. It's been a few years since I've been in touch with the mother, but the last when I spoke with the mother, he'd been doing very well in his new residential school there. So it was a very positive outcome in this particular case. Right. But I also want to point out that by no means was this an easy process, right? So you can see in the the baseline videos that our staff were getting beaten up. They had to wear protective equipment for their safety there. His admission probably took, I think, about 3.5 to 4 months, which is a pretty standard for the Kennedy Krieger Institute's neurobehavioral unit in admission there. And it took a dedicated a team of well-trained staff to really get him to the point where he could be discharged and really excel in the community there in his residential placement there. So I don't want to paint this again. I don't want this to seem like this before and after picture was like something that could be done overnight. It really did take a lot of people's effort there. So now I'm going to turn it, to the hospital, this, say psychiatric hospitals there, and how ABA could work in the environment there, and how it is currently working in the environment there, right? So in all likelihood, the patients that you guys are working with have a very long history of the complex problem behaviors being reinforced, right? So, but the fact that they're in the hospital with you guys means that there are very challenging issues. In many cases, it revolves their problem behaviors there. In most cases with your patients, it's likely the case that they've learned these behaviors over time. Some patients might have had like earlier access to treatment. Others may not have, unfortunately, there. But I think really the goal of this ABA-based interventions or support is really to improve the socially significant behaviors. Right. So the question is, are the individuals a danger to themselves or others? And also, does it impede, or do these behaviors impede learning or their independence? Really, their ability to function independently, to live independently, and keep to get and maintain jobs there. And so again, I want to point out that this is by no means a quick fix. It takes a lot of work, a lot of people power to do this right. And it also requires well-trained staff who know what they're doing there. But it also requires a consistency in the implementation of treatment, right? So the behavior analyst can do a wonderful behavioral assessment and then develop a wonderful behavioral treatment based on the results of that behavioral assessment. But if the treatments are not consistently implemented, then the treatment will, in all likelihood, fail there, right? So follow through is a very important part of this there. So in terms of the behavior analyst in the hospital, right? So you might know the people as behavior analysts or their certification, which is the BCBA, Board Certified Behavior Analyst there. So behavior analysts are professionals who deliver ABA-based intervention, right? So they're master's level clinicians who all have a certification that's called the Board Certified Behavior Analyst, or the BCBA, and that's the primary certification within our field there. I should also note that within probably the next year or so, New Jersey will also license the practice of ABA. Governor Murphy signed the law, I think, a year or two ago, but they're currently finalizing the regulations for implementation there. Okay, so the profession, or the professionals, are called behavior analysts, and their title or their certification is a BCBA, Board Certified Behavior Analyst, but they're also members of the interdisciplinary team. Right. So I know that all the behavior analysts that I work with are really important parts of the interdisciplinary teams for the patients there. Right. So they're working with psychologists, psychiatrists, medicine, nursing, OT, all the disciplines, so that as a team, the outcomes are the best as possible there. Just to kind of give you an idea of who the behavior analysts are. Hopefully, have met the behavior analysts in your hospitals there. Right now, Ann Klein is their behavior analyst position is vacant, but we're trying to work with the folks over there to get someone trained up there. But please reach out to these behavior analysts to learn more about what it is they do and how they can support the patients that you guys work with, if you haven't already done so there. What can behavior analysts do, or what are they currently doing? Well, right now, a lot of their work is assessing and treating, the very challenging behaviors that your patients exhibit. But they're also working on, teaching, focusing on compliance and skill acquisition. So, for example, a lot of the work tends to be, on like teaching 8 activities of daily living, like showering, for example. Or helping your patients comply with various therapies or other types of activities there. A lot of their time is also spent on staff training. So I mentioned just a little while ago that consistent implementation is very, very important and integral to the success of treatment, and that involves staff training, making sure that all the staff people, the DSPs who are going to implement the treatment, know how to implement that treatment there. Finally, what can behavior analysts also do? They can support other disciplines, right? So, I mentioned that, for example, we're really good at collecting data. So if there are medication trials, for example, that are ongoing, then the behavior analysts can collect data to really show whether or not the medications are having any benefits there. But also, really focusing on a lot of skill development there. So I'm going to end my talk with one last video. And so I want to make sure I come back to the first patient that I showed you who engaged in that really severe self-injurious behavior. And so with her, we found that a lot of her self-injury was some type of sensory stimulation. And so we found what we referred to as competing items. So she liked these kind of like stringy objects just to kind of hold and play with there. And then the other thing is that, because her SIB was now essentially treated, she can now actually do vocational or schoolwork activities, which she had never been able to do because of the severity of her self-injurious behavior. So this is just an example of just a very simple sorting task. While she still has access to her competing items there, but you can see that she's successfully completing that sorting task there. So I'm always happy to talk about ABA. So this is my email address, and you are more than welcome to shoot me an email with any types of questions we have. And we've got about, I think, 5 or 6 minutes for questions. So hopefully that's enough time.
We do have a couple minutes for questions. So if anyone has that. Tom asked, the large study in the 1970s used a form of ABA to successfully extinguish psychotic behavior. What do you think of this?
Yeah, you know what? I think you're right. So Tom, like in the 70s, there were some studies that looked at the use of ABA for behaviors like schizophrenia or other, like hoarding, for example, amongst schizophrenic patients, and they were very, very effective. I think that that is a wonderful opportunity to continue to apply at the hospitals here. I think that there was really a shift from like behavioral interventions to more of a medical or psychiatric model. So I think within the psychiatric population, there's been a movement away from ABA. But I think it'd be awesome and a huge benefit to your patients if we can get ABA, I guess, more common as one mode of treatment within the hospitals there, which is why I'm there.
And can we use ABA with staff? I'm not sure how serious of a question that was, but
yeah, well, and the answer is actually yes, because all of our behaviors are really affected by like how other people respond to them, right? And so actually within the field of ABA, there's a subset called organizational behavior management. And that's like industrial organizational psychology there, looking at like helping to improve staff safety, staff performance, and things like that. So it is doable.
any other questions for Dr. Kang? While you're thinking of your questions in the last 4 minutes, I did post the link to the training evaluation. I'll send it out again in the morning, just in case you don't have a chance to do it this afternoon. But that does give you access to the handouts and the slides from today's presentation, as well as a certificate of attendance that you came to today's webinar. Another question, in DBT, they use chain analysis. What are your thoughts?
I've got to apologize. I know of DBT, but I'm by no means an expert in that. So that's a question that's really difficult for me to answer. But I'd love to talk to you guys about DBT and see how that might fit in.
Okay, fair enough. If BCBA was not available, then who can take up that role?
Yeah, that's also a good question. So I know that the behavior analysts, like each hospital kind of deploys their behavior analysts differently. So for example, I know in Ancora, the behavior analysts are in specific units, and they don't really go outside that unit. They're assigned units there, and that's really that's because of their capacity, right? So there's only a certain capacity to work with the patients there, and so I think it's a matter of talking to the administration to see, can you get more behavior analysts or more people with expertise within this other units to try to help support those patients there.
And another question that came in, what are the counterindications for ABA, if any?
That's hard to say, right? So I think that, if I guess one thing to consider again is that ABA, like the treatments based on ABA are not easy to use, right? It's not like a medication where they take it once a day and then within a couple of weeks, they receive a therapeutic, they reach a therapeutic dosage, right? This is something that needs to be done every day for a long period of time. You can gradually fade away the treatment components eventually, but that's going to take a long time. So that's one thing to consider is do you have the resources to do it right and do it consistently there.
And another question, have you seen any other variations or alternatives of FAs to be effective?
There are actually lots of different ways to do functional analyses there, all right? So, and again, it's designed to really meet the needs of the particular patient, as well as the setting in which the patients are doing or living there. So it's very flexible, but again, you have to have the expertise and the skills to know like how to modify the functional analyses or functional assessments there.
Quick comment from Dr. Zika says she said this type of presentation needs to be given to the CEO and all administrative people and nursing department, but more in depth and role playing. So this is really something that everyone needs to know.
Yeah, great. And we did a couple years ago, We did make presentations to the administration and some of the leadership staff across the different hospitals, kind of like a lighter version of this presentation. But yeah, we're happy to talk more about it. The behavior analysts, BCBAs, are more than happy to talk about this.
Great. And final question, what is the role of RBT and ABA?
Great question. So RBT is a certification for the behavioral technician. So kind of like that direct care level. So the RBT certification, it really kind of gives you like a minimum, that they've reached the minimum standard of training and experience. By no means does it mean that, like everything is perfect, right? So, and so like the BST position, we've incorporated RBT training, but we haven't necessarily required actual certification. Although I think some BSTs are looking to get certified as RBTs as well.
Okay. Well, it's 4 o'clock, and so we'll end there with that final question. Thank you, Dr. Kang, so much for being here. This was very, very informative. And again, if you want to get the handouts from the training evaluation, the recording of the webinar will be available on the Rutgers website tomorrow, and also our YouTube channel, so you can watch it again. And if you have any questions, you can email Dr. Kang, and his information will be on the slides as well. So thank you so much, everyone, and we'll see you next month. Take care.
Thank you.